Hello, everyone, and welcome to the February Dutch webinar. I'm Noah Reed, Vice President of Sales and Marketing for Precision Analytical, creators of the Dutch test. Today, we are excited to bring you an expert in women's health, Dr. Tori Hudson. Dr. Hudson is here to explain secondary amenorrhea and give you tips to treat your patients who may be struggling with it. Today's webinar is one of many educational resources available through Dutch. Visit us at dutchtest.com and find a vast library of videos and educational resources to help you understand hormones and treat your patients' complex hormone-related issues. Coming soon, we will also be launching a full online education course with in-depth topics to help providers become hormone experts and profoundly change the lives of their patients. This free course will only be available to registered Dutch providers, so sign up today and be one of the first to gain access to this amazing new course. Signing up as a Dutch provider is easy. Just click the link we've posted in the chat and complete the Become a Provider form on our website. If you sign up today, you'll also receive 50% off your first 5 test kits, plus patient referrals and access to even more valuable education. Now, a few housekeeping notes before we get started with today's webinar. You can find today's slides in the handout section of the control panel on your screen. This webinar is also being recorded, and everyone who registered will receive the recording via email tomorrow. If you have questions along the way, add them to the questions section of the control panel as well. We will conduct a short Q&A after the presentation if time allows. Lastly, please keep in mind that the contents of this webinar are for educational and informational purposes only. The information is not to be interpreted as or mistaken for clinical advice. Please consult a medical professional or healthcare provider for medical advice, diagnosis, or treatment. Patients can find a list of Dutch providers in their area on our website through Find a Provider button at the top of the page. And now, let me introduce today's speaker. Dr. Tori Hudson is a naturopathic physician who graduated from the National College of Naturopathic Medicine in 1984 and has since served at the college in many capacities, including professor, medical director, and academic dean. She is currently an adjunct clinical professor at UNM, Southwest College of Naturopathic Medicine, and Bastyr University. Dr. Hudson has been in practice for more than 38 years. She is the medical director of her clinic, A Woman's Time, in Portland, Oregon, and is the director of product research and education for Botanical. She is also the founder and co-director of Naturopathic Education and Research Consortium, a nonprofit organization for accredited naturopathic residencies. In May of 2021, she received the Freddie Kronberg Excellence in Research and Education in Botanicals for Women's Health Award from the American Botanical Council. This prestigious award is presented to the researcher, educator, or clinician who furthers the scientific study, education, and clinical use of medicinal plants and phytomedicines for women's health conditions. Dr. Hudson is also a nationally recognized author, speaker, educator, researcher, and clinician who serves on several editorial boards, advisory panels, and a consultant to the natural products industry. Thank you for joining us today, Dr. Hudson. We're all ready when you are.
All right, my pleasure. Thank you so much. And I just want to thank the Dutch test team overall for inviting me to speak. And I just really also want to commend you all at Dutch for offering practitioners content that may or may not directly be relevant to Dutch testing. I appreciate that, and just in the spirit of women's health and education of consumers, clinicians, and my motto, how do we help more women more of the time? So I appreciate that you all are up to that in all kinds of ways. I'm speaking to you from Portland, Oregon, by the way, and this is my normal time when I be eating my dark chocolate right after lunch, but which is now currently my source of cadmium and lead, apparently. And I'm sure you all have been reading about that. So I've been enjoying trying to find out where I can get the best chocolate with the least cadmium and the least lead. I think this has already been read to you by the Dutch test folks. And the disclosures, he mentioned Vitanica. I am co-owner of Vitanica as well, and I do serve on the scientific advisory boards of a few different entities. But let's start with our topic of amenorrhea. And by the way, I'm going to go in and out of my video, so don't be alarmed if you can't see me. I'll be coming back and forth. So amenorrhea, as it turns out, is kind of one of the most challenging problems in gynecologic endocrinology. And the reason why it is because there's just an array of potential diseases and disorders that involve multiple systems, and in some cases carry morbid or even lethal consequences. So it can be complex, but if we are attentive and methodical, we as practitioners, and stick with the process that I'm going to outline today in the workup, which is it all starts with the workup. A diagnosis can be made from this presenting symptom of secondary amenorrhea. And by the way, there's also primary amenorrhea, and that's when someone does not have a menses by age 14 in the absence of growth or development of secondary sexual characteristics, or no menses by 16, regardless of the presence of normal growth and development and secondary sex characteristics. That's all primary amenorrhea. We're not going to talk about primary amenorrhea today. We're talking about secondary, which is the menses has occurred at some point in their past, even if it was just a little bit, even if it was one time. But now it's not occurring, and it has not been occurring for 3 months if they have a history of regular cycles, or it's not occurring for 6 months if it's been a history of irregular cycles. All that is the definition of secondary amenorrhea. And you can see the prevalence up above, and especially women with infertility, 20% of those cases of infertility are caused by secondary amenorrhea. All right, so let's start with how do we understand some basic principles. And if we understand, I'm going to assume that we all understand sort of basic principles of menstruation. Then we can see these discrete compartmental systems on which that menstrual function depends. So our evaluation today is going to segregate the causes of secondary amenorrhea into these 4 compartments. Compartment 1 is where there's some problem with the outflow tract. It could be that the os, the cervix is stenosed. It could be, in the case of secondary, of course, in the case of primary, they could be absent some congenital absence of major significance. But in secondary amenorrhea, it's more that os would become stenosed, closed off, and the blood actually cannot escape. Um, or the uterus itself is not, there's something that has occurred over time where it's been damaged, such that it can't receive that estrogen stimulation in particular. But also progesterone. Compartment 2 is problems in the ovary. Compartment 3 is problems in the anterior pituitary. And compartment 4 is disorders of the central nervous system, the hypothalamic factors in particular. The history and the physical exam should seek to evidence for start with the stress aspect, but don't assume that or presume that or just say, oh, she's stressed, that's why. We include that, but then we need to go on, because there also might be some family history of some genetic meaning. There might be, we should look for problems with the focus on nutritional status. Do we have reason to think that they're malnourished? Do we have reason to think that they are on extreme diets? Do we have reason to think they have disordered eating or anorexia or bulimia, especially anorexia? Do we have information about their excessive exercise? And the combination of excessive exercise and eating disorder are sort of the most wicked combination of the two. And then are they having, normal or abnormal growth and development of breasts, for example? And that's I think that covers it. Let me just look at the illness. There might be some medication that could be happening here. For example, even a young woman can get breast cancer, can be or some other cancer, and local pelvic radiation and or systemic anti-hormonal therapy or chemotherapy. All of those can cause secondary amenorrhea and essentially premature menopause. That is one of the causes of secondary amenorrhea. So medication history is important. Her specific menstrual history is very important. How old was she? Did she ever have regular menses? If so, when was that? When did they stop? Does she have some other chronic illness um, that might be related? We'll talk a little bit about that. Like, do we know she already has hypothyroidism, as one small example? There's also the issue in terms of her review of systems. We want to know if she has galactorrhea or nipple discharge. This is an important sign, and whether it's spontaneous or whether it occurs only when the nipple and breast are compressed and expressed. And it can be an important sign whether it's one breast or both breasts, and whether it's persistent or intermittent. All that has potential is important to know. Now, hormonal secretions that are uh, you might say benign, meaning non-cancerous. These hormonal secretions that cause galactorrhea usually come from multiple duct openings, which you can actually see when you're looking at the nipple. How many of those duct openings is that the galactorrhea being is coming from? Uh, because a pathologic discharge usually comes from a single duct and only one breast. So that would be a breast cancer or perhaps a papilloma, which can be benign. And if they have both amenorrhea and galactorrhea, we actually proceed with the evaluation of the amenorrhea first, and then we add the other evaluation of galactorrhea after that our amenorrhea evaluation is done. The physical exam, we're looking secondary sex characteristics. We're looking for evidence of hirsutism, acne, hair loss, something on the skin, not just acne, but something called acanthosis nigricans, which is a dark discoloration in the body folds and creases. Usually it happens in the armpits and the groin, or armpits or the groin, and or the neck region. So here, groin and neck region. Um, and then we want to know how much she weighs and what her height is and assess her body mass index. Does she have proper sexual maturity? I think that's everything on this list. Let's see. And then we're going to get to testing. So the next section of before we get to therapeutics, this is a little bit weighty in here with evaluation and workup, and you're going to need to refer to these slides, you clinicians who are hopefully going to adopt this workup, because it's not going to be easy to grasp just with a one-time through. There is a very important chapter in a very important book called what is it called? So I'm looking at it, Clinical Gynecologic Endocrinology and Fertility by Leon Spiroff. I think the last edition was a few years ago. It's still, that amenorrhea chapter is golden. I recommend that my residents actually read that chapter 4 times before they really kind of get the drift of it all. It usually takes about 4 times. And then, of course, it takes, having 1, 2, 3, 4 patients that you're walking through it before you kind of get comfortable. So these are the tests that we're talking about at different points along the algorithm here that I'm going to lay out in the next few moments. What you notice is there's no salivary testing or urinary testing on here. And that's because the algorithms for a clinical diagnosis uh, of a medical condition that's underlying the cause of secondary amenorrhea does not include any of those kinds of tests. Now, that you could certainly do other functional medicine testings, such as a dust test to for some other aspect of their health, or their medical history, their family history, breast cancer, for example. But to diagnose their cause of secondary amenorrhea, we need to really focus on knowing how and when to use these tests and the meaning of the results of these tests. So step one starts with, are they pregnant? And you can decide if you want to conclude that you're comfortable with their answer to your questions about sexual activity with the uh, and intercourse with a male partner, i.e., sperm exposure, uh, and or if the history is adequate, or if you should do a pregnancy test. And sometimes that's a delicate situation. But the baseline testing is determine if they're pregnant or not. A TSH test, you don't need to do all the other hoopla for thyroid for this algorithm, and a serum prolactin level. That's the initial step. Um, and if she has an elevated TSH, and by elevated I mean actually beyond the 4.5 reference range, it would be very rare, but not absolutely impossible, but very rare for a gray zone TSH, like a 3.0 TSH, to cause secondary amenorrhea. Now, if she, so what, which I would call sort of suboptimal, but not hypothyroid. Now, maybe that gray zone between 2 and 4.5 TSH could, along with her being underweight, along with her being highly stressed, then maybe we could see the influence that she's more vulnerable to that suboptimal TSH. Of course, if she's hypothyroid, we treat her hypothyroidism as the treatment for her secondary amenorrhea. Obviously, if she's pregnant, we go from there. Elevated prolactin levels, we have to decide when we do imaging. And so there are some cutoffs with some numbers you can look up versus monitoring just the serum prolactin. But it's elevated. Definitely, I think the number is above 100. Don't quote me on that, but I believe that's the case. We need to determine if there's a tumor involved. And imaging with a what they call a cone down X-ray of the sella turcica is what is, I think, the still standard of care. If all these are normal, she's not pregnant, she's not hypothyroid, she doesn't have elevated serum prolactin, then we go on to what is called a progesterone challenge test or progestational challenge test. So that the purpose of this, it's very important that you understand this. The purpose of a progesterone challenge test is to assess the level of endogenous estrogen and the competence of her outflow tract. And there are 3 different ways to do that that are accepted in what you might call standard of care, conventional algorithm and workup and evaluation of secondary amenorrhea. One is a synthetic progestin called medroxyprogesterone acetate, or MPA, 10 milligrams a day for 5 days. Another is you could use oral micronized progesterone, 300 to 400 milligrams a day for 5 to 7 days. Frankly, in this case, I wouldn't get fussy. Oh, you want to use bioidentical versus synthetic. It's only for a few days. And actually, progesterone at 300 to 400 milligrams might more likely cause immediate side effects like sedation or groggy or dizzy or lightheaded or drunken feeling. Might more likely cause that within the few days than would the MPA. And the MPA is stronger, even that 10 milligrams versus 400 milligrams is stronger. So you do get, I think, a better test, you might say. One can use parenteral progesterone. I don't do that, so I stick with either one or number 2. Within 2 to 7 days after the conclusion of the progestational medication, the patient will either bleed or she won't bleed. Now, if she bleeds, we get to make a diagnosis of anovulation. And we know that's reliable and securely established because she's having a withdrawal bleed after this progesterone challenge. Even if she just has a few tiny blood spots following a progesterone challenge, that does in fact imply at least a marginal level of endogenous estrogen, and it implies the presence of a functional outflow tract and a uterus. And we now know that there is a uterus lined by a reactive endometrium sufficient that it can be stimulated by her endogenous estrogen. We've confirmed all of that. And with this confirmation of the presence of estrogen, at least some minimal function of her ovary, her pituitary, and her hypothalamus has been established by this simple test. With this positive withdrawal bleed in response to the progestogen challenge, and in the absence of galactorrhea, and in the presence of a normal prolactin, normal TH, we don't have to do any further evaluation necessary because this combination of things effectively rules out a significant pituitary tumor, and we know she's not ovulating. Now, her ovarian estrogen production is good. What's not good is she's not ovulating. So then we can further understand that. Is it because she's stressed? Is it because she has PCOS? So there is a little bit more work to do there. But we had our history that hopefully leads us in the right directions. You notice what's not on here is progesterone cream or progesterone troches. Please do not use those for this test called the progestational challenge test. They are not adequate. They are not proven entities to accomplish the uh, reliable information that we need. There are some rare situations associated with a negative withdrawal bleed despite the presence of adequate endogenous estrogen, so that I'm about to confuse you, but one of those is PCOS. PCOS women have adequate estrogen. They have adequate hypothalamic pituitary ovarian axis orchestration happening. But what they do have is insulin resistance and hyperandrogenism, and that's interfering with the maturation of their follicles and ovulation. So that's not so rare. But the second situation is the endometrium is decidualized by high progesterone levels associated with a very specific adrenal enzyme deficiency. If there's no bleed after the progesterone challenges, not even a spot, then the problem is either the target organ is a problem, meaning the uterus, or there's some kind the estrogen proliferation of the endometrium has not occurred. So now we're trying to figure out, well, what's that about? So when there's no bleed with the progesterone challenge, this is step 2. This step is designed to clarify the situation. Is the problem the uterus? Is the problem the orchestration with the HPO axis? And orally, in order to begin to sort this out, now we give basically orally active estrogen in a quantity and duration that's certain to stimulate the endometrial proliferation, and with a progestogen is certain to cause a withdrawal bleed, providing that she has a reactive uterus and a good outflow tract. So that is why we give, I would say, one of these two methods. You can give either an oral estrogen, CE stands for conjugated equine estrogen, that's Premarin, which 1.25 is double your average dose, or you can do bioidentical estradiol, 2 milligrams is twice your average menopausal dose, I should state. And you do that for 21 days, and then you bring on the MPA for the last 5 days. Another way to do it is a birth control pill. I would recommend a 30 microgram pill, not a 20, and definitely not a 10. And remember, the goal is to clarify the situation. We have to give enough active estrogen in enough amounts and duration to stimulate that endometrial proliferation. So don't use a cream, don't use a vaginal estrogen, use one of these two methods, please. The purpose of these is a test. We're testing these. We're using these hormones as tests, not as treatment. So if there's no withdrawal bleed So how we got to this step is there was no withdrawal bleed from the progestogen challenge. Now there's no withdrawal bleed with giving estrogen and a progestin. So if this means the diagnosis of a defect in compartment 1 systems can be made. So we look back at compartment 1. Compartment 1 is a problem in the outflow tract or the uterus itself. So no withdrawal bleed with progestogen, no withdrawal bleed with estrogen and progestogen. The problem is in the compartment 1. If withdrawal bleeding does occur with this step 2, now we can assume that compartment 1 systems have normal function capacities. They can receive estrogen and they can exit the lining of the uterus and the tissue and the blood if it's properly stimulated by the estrogen. So if the patient has normal external and internal genitalia by exam, and in the absence of a history of infection or trauma, we actually then go on to step 3 because she had a withdrawal bleed with this purpose, with this regimen. The purpose of, so if she bled after our estrogen stimulation, again, we now know that her endogenous estrogen is actually not adequate to stimulate the endometrium. But now we need to know why. And because we proved it wasn't adequate in step 1 because she did not have a withdrawal bleed. We got to step 2, we even gave her estrogen. It still didn't occur. So in order to produce estrogen, the ovaries have to contain a normal follicular apparatus and sufficient pituitary gonadotropins to stimulate that apparatus. So this step 3, is designed to determine which of these true crucial components is functioning improperly, the gonadotropins or the follicular activity. So it's designed to determine whether the lack of estrogen is due to a fault in the follicle, which is compartment 1, or is it a problem in the CNS pituitary axis, which is compartments 3 and 4. So what do? Now we test her serum FSH and LH. And I know what too often occurs, someone has secondary amenorrhea, and we just throw a bunch of tests at them. Throw estrogen, progesterones, FSH, LH, thyroid. What didn't I mention? Other functional medicine tests. We just throw the gamut at them because we actually kind of don't know what we're doing. If we do that, would be my assertion. And going through this step, we might have never even gotten to needing those tests. This methodical algorithm pays off in efficiency of diagnosis, accurate diagnosis, and cost of testing, cost of knowing what's going on. We reduce our costs. Okay, so step 3 continued. So what if her outcome is an FSH that's elevated and an LH that's elevated? And what I elevated here, we mean greater than 20. The association between high levels of gonadotropins and ovarian failure is very reliable, but there are some situations in which high gonadotropins can be accompanied by ovaries that contain follicles. So there are some rare tumors that can produce gonadotropins, even that's actually associated with a lung cancer, oddly enough. There's a handful of reports of a single gonadotropin deficiency, maybe a high level of one and maybe undetectable or baseline normal of the other, and there might be this homozygous mutation in the gonadotropin genes. I've never seen either of these two situations, by the way, in 38 years. And then there are situations rare where a high FSH and a low LH could occur, and this would make us suspect a gonadotropin secreting pituitary adenoma. But these are all rare tumors that are FSH secreting. And most of these case reports are actually in men. So what we're looking for is this FSH in particular above 20, i.e., is it in the menopausal range I put POF, premature ovarian failure. I should update that. The premature ovarian insufficiency is a more commonly used term these days. So what if she has an elevated FSH and a normal LH from our test? Well, during that perimenopausal period, it's actually normal for FSH levels to begin to rise even before bleeding has ceased. And that is a very labile number, FSH, in perimenopause. So this is true whether it's perimenopause at the normal age or it's perimenopause prematurely. Um, and during that perimenopausal period, those remaining follicles, you might say, are the least sensitive of all the follicles because they've remained in place and failed to respond for gonadotropins for all these many years. So as these remaining follicles begin to respond to that rising FSH level during perimenopause, the production of inhibin is also maybe inadequate because that is responsible for a negative feedback as well. So the patient can have elevated levels of FSH despite continued bleeding or very recent onset of their amenorrhea. So we kind of need to pay attention to this situation because a period of postmenopausal levels of FSH can be followed by a pregnancy. So that's why we want to measure both FSH and LH so that we can understand if she's truly perimenopausal or not, which is associated with high FSH but normal LH. And then we have the elevated FSH, LH in what's called resistant or insensitive ovaries. I think I might let you read a little bit about that because that condition is rare. They can, sometimes they even have to do laparotomy to look to find follicles deep within the ovary. It's maybe possible that ultrasound can be used to see if there's a low number of follicles, but this is where she has elevated gonadotropins despite the presence of ovarian follicles. Remember, we're getting to these tests and these interpretations because of our earlier steps, and in particular, our earlier steps. And then secondary amenorrhea due to premature ovarian failure or premature menopause can be due to autoimmune disease. So this is where maybe thyroid antibody testing could be helpful, but also does she already have myasthenia gravis or ITP or rheumatoid arthritis or vitiligo or autoimmune hemolytic anemia or true adrenal insufficiency? I'm not talking about, you know, a functional medicine test that shows adrenal this and that, but I'm talking about true adrenal insufficiency measured by challenged, they have to get these shots to challenge their adrenals to really diagnose that. But a classic case of premature menopause or POF or POI can precede adrenal failure. So monitoring adrenal function is might be important. And then the final situation associated with high gonadotropins and normal ovarian follicles include a galactosemia and an enzymatic deficiency in both ovaries and the adrenal glands. This person, though, would present with absent secondary sexual development and might be hypertensive. Okay, what about this situation? She has normal gonadotropins. So this is the one you're going to see, and you're going to maybe scratch your head. Well, those are normal. So normal FSH, normal LH, this is hypothalamic amenorrhea. And there's no other test that you need to know because we've gone through all the other steps and now we do know. And remember, we got here because of our previous, in the patients with normal exam and the absence of history or infection, she had a withdrawal bleed from the birth control, not from the progestogen, but from the birth control pills when she was properly stimulated by estrogen. But we want to know, why isn't she producing enough of her own? So if we get to this place in the algorithm, boom, we get to diagnose hypothalamic amenorrhea. And then there's low FSH or normal FSH, LH. That's one final step to distinguish between pituitary or CNS hypothalamic cause of amenorrhea, and that is where we have to come back to that X-ray evaluation of the Sella turcica. I don't think I said that right. Okay, what about congenital abnormalities? Those are limited to secondary amenorrhea, which presents in the puberty time period. In a study of almost 300 women with secondary amenorrhea, the chart kind of breaks down like this. So you see there might be, so Turner syndrome is something you'll probably see. Certainly premature menopause is definitely something you'll see. And anovulation is the most common. Is it stress? Is it PCOS? Not very often is it actually hypothyroid. Okay, now we're going to go to um, our natural treatment interventions. But again, I'm going to perhaps annoyingly stress we have to make an accurate diagnosis from these tests, this algorithm, to know that we're treating the right thing. You don't just say throw Vitex or maca or black cohosh or seed cycling or whatever else you can come ideas you might have uh, at a secondary amenorrhea person without knowing the cause, because the causes are very different. They're treated very differently, and each of them is associated with future different risk of future health problems. PCOS associated with future risk of type 2 diabetes, heart disease. Hypothalamic amenorrhea, if not treated properly, associated with osteoporosis and fractures. Premature ovarian insufficiency associated with if it's not treated adequately. Uh, Risk for osteoporosis, fractures, heart disease, possibly Alzheimer's disease, and just premature aging of everything, skin, bones, eyes, everything. Let alone quality of life issues in all of these that I'm mentioning. So we need to understand that underlying cause with our methodical workup and going through those evaluation steps and coming to what is the underlying cause or causes. Um, and Now we get to manage that underlying cause, any complications associated with that. She's PCOS, we need to be mindful of the long range plan too, preventing diabetes and heart disease, especially if she's obese. Uh, so prevention in addition. So don't just set your eyes on, oh, I want her to have a menstrual period. We need to set our sight on the menstrual period as a reflection of her endocrine health, quality of life issues that she's having that she doesn't want to have, like infertility, acne, hirsutism, depression, and prevention of big time future diseases that we can actually reduce the risk of. So these, at least the first 6 bullet points will look familiar to naturopathic physicians. There are principles. I also have the Tori Hudson, I'd say principles of resonance and choice. Resonance being what's right for this, what's the right treatment plan relative to not just the disease and the condition, but their other um, health issues, their way of life, their finances, their abilities to take things and do things. That's all about resonance. And then ultimately with the right education, they get to choose what they're comfortable with. Then there's also perhaps some, other things we're going to have to kind of address, especially if it's relating if her condition PCOS, POI, or hypothalamic amenorrhea are going to affect her fertility. So there might be conversations and addressing her emotions about that. There might need to be some other childbearing or child rearing options that need to be discussed either with you or someone else. She might have this be having secondary amenorrhea, as I mentioned much earlier, due to medication. Some of those medications related to cancers, and certain cancer treatments do increase the risk of premature menopause. So we have that is essentially then a side effect of that cancer treatment. And then we are going to need to give her treatment options. We're going to talk about, I have listed here just hormonal contraception and menopausal hormone therapy. And you might ask, well, why isn't botanicals and lifestyle on this list? She's prematurely menopausal. That means she stopped having her period due to premature ovarian insufficiency, which we learned from our algorithm and workup and tests. And the standard of care for her is that she be on menopausal hormone therapy or birth control pills until she's 51. That is the standard of care. If you don't do that, you are risking her future osteoporosis, heart disease, fractures, Alzheimer's disease, premature aging, dying a few years earlier than she would normally have died, and a few years earlier than she would die if compared to taking hormone therapy. So that's why botanicals and nutraceuticals are not the on this list. That's not to say you can't do them in addition. Bone prevention, heart disease prevention, other quality of life issues for sure. But the primary treatment for POI should be some proven doses and delivery of estrogen and progestogens. I'm stressing proven because she does have a uterus. You give her estrogen, we got to give her proven doses of progestogen to protect her uterine lining. So here are some, might we investigate environmental exposures, autoimmune genetic causes? Yeah, we might do that. So there are some examples. EX means examples of hormone regimens that are accepted and within standards of care proven to protect her uterine lining from endometrial cancer, proven to provide estrogen support for the aging process, all the things that I mentioned. Those are all accepted regimens. And it looks like even the estrogen patch, the 0.1 patch, which is the double the average dose patch, is superior to a 30 microgram birth control pill in improving bone mineral density in women with POI. That's a little bit surprising, but there is some evidence to show that. Now, could you try something non-hormonal for a period of time just to see if this is the cause, POI? I would not do that for any longer, 6 months max. Now, she might already have been amenorrheic for 6 months, so she's already put in her 6 months of estrogen deficiency, you might say. So with that, I don't really want to go another 6 months. That's a whole year. That's going to cost her in her future. So I might say, okay, we'll go 3 months. And to see if we can get a menstrual cycle going with these things. So that's kind of a tough call, but the main message is don't go too long with non-hormonal proven treatments to prevent these big time future diseases in a POI case. These are just some other things that you might consider exploring if you want to explore environmental exposures. If there's an environmental exposure, could you reduce her exposure, and probably you could, but could you get it out of her system or get it out of the sphere of influence on her menstrual cycle in any amount of time, let alone a short amount of time? That's questionable. Just again, a note about you got to keep your eye on the long range plan also for POI, the osteoporosis, the heart disease, the Alzheimer's, and that when we haven't even gotten to hot flashes, insomnia, night sweats, vaginal atrophy, etc., insulin resistance, dyslipidemia, and more. Okay, premature ovarian failure. This is a repeat, I think, but maybe a little bit more specific. So she's prematurely menopausal, POI. Could you do something for a few months? My vote would be hang heavy on the maca, but I have some other ideas there. All the while thinking, okay, yes, we're going to do that, but we got to help protect her bones, her heart, her brain. So we can do fish oils and minerals and vitamin D and exercise and soy and all those things to also think of her future while we're also addressing the now, but don't go too long. That's a repeat. I'm sorry, I have repeat slides in here. Another repeat. Okay, what about when she has anovulatory amenorrhea unrelated to PCOS, hypothyroid, or hyperprolactinemia? So who might, this was where I'd be looking, is stress really the cause? It could be. And she doesn't fit the criteria of hypothalamic amenorrhea in our algorithm. But I'm not going to just assume stress from the get-go, even if I've heard some horrible story. I'm still going to go through my algorithm. Progesterone precursor herbs, do they have a role here? Certainly not for a progesterone challenge. They might have a role in our short-term plan that could stimulate ovulation. Black cohosh should actually be on there, but they don't, although it doesn't contain diasgenin. But it adheres on this. There's a study in PCOS patients. Let's see, I don't think I have it here. Black cohosh, 10 days out of the month, 40 milligrams extract stimulated ovulation. And then I just have these traditional botanicals and their role as tonics, as sedatives, improving muscular tone. All those might have a role short term, especially in the anovulatory patient who doesn't have PCOS, doesn't have hypothyroid, doesn't have hyperprolactinemia. Black cohosh can be used certainly in a POI patient who's hasn't had a period for 6 months. She's less than age 40, so she's prematurely perimenopausal. But we could take 3 months and see if we could get things going with black cohosh, tribulus, chase tree. Rhodiola is an herb not everyone's familiar with in terms of an ovulation support herb. And this was just a small study. These were women who had secondary amenorrhea, but we don't know the causes. The paper didn't have the causes. But nonetheless, it's what 15 out of no 25 out of 40 women became regular menstruators, and 11 of them became pregnant. And then Vitex, good old chase tree berry, that can be used in PCOS to help stimulate ovulation. But remember, the core problem with PCOS is insulin resistance, hyperandrogenism. So that has to be the core of your treatment plan. So we'll come back to that. But I'll talk about Vitex or chase tree berry for elevated prolactin. We know that the basic function of chase tree berry in the reproductive situation anyways, it seems to stimulate the release of luteinizing hormone from the pituitary gland and mildly inhibits FSH. And by doing so, it has this indirect ability to modulate progesterone. So meaning if you stimulate ovulation, now she has a corpus luteum that produces the progesterone. That's what has to happen to have endogenous progesterone production. But it's also, Vitex can modulate the secretion of prolactin, and I'll show you a little bit more about that. This is a small study showing that 6 of the women had a secondary amenorrhea, and using a simple chase tree, they developed 1 or more menstrual cycles. And this nice old-fashioned 40 drops of chase tree berry tincture, 15 out of 20 had the onset of menstrual cycles after having secondary amenorrhea. Flax seeds, this study basically just shows that you can have more, women who took a certain amount, 10 grams of flax seeds a day for 3 months, had more ovulatory cycles than women who weren't having ovulatory cycles and weren't having regular menses. I'm not a fan of the seed cycling because these seeds don't work that in a short-term way, just like Vitex doesn't work short-term. You need a few months typically, 2, 3, 4 months to see Vitex work. I don't think you need only 2 weeks to see this seed work and 2 weeks to see that seed work. That just doesn't make sense to me. So I kind of discourage that line of thinking. But this study, flax seeds, 10 grams every day, does seem to yield more ovulatory cycles in women with secondary amenorrhea due to anovulation. So chronic anovulation, here you see the flax seeds. You could do cyclic progesterone, either a oral, that's OMP, or lower dose, a cream, much lower dose. You're not stimulating ovulation, by the way, by doing that. You're merely helping to promote the withdrawal bleed. We're going to use rhodiola and perhaps Vitex and the flax seeds to stimulate ovulation. Simplex F, I apologize, I try not to do proprietary things, but that's a multiglandular formula that has several bovine source glands in it that it's one of the few glandulars I've hold on to over the years because I've seen it work. And then PCOS, make sure you understand what are the criteria for diagnosing PCOS. It's very specific and at the exclusion of other etiologies of her secondary amenorrhea. So make sure you understand that. And then there's this is the Rotterdam criteria, and then there's the Androgen Excess Society has a little bit different criteria. So PCOS is the most common endocrine disorder of reproductive age women worldwide. And there are high risk groups. Obesity is one example. Premature adrenal dysfunction, first degree relatives with PCOS, type 1 or type 2 gestational diabetes. But then the PCOS might be the cause of secondary amenorrhea, but what's the cause of PCOS? Well, we know it's hyperinsulinism and hyperandrogenism, but we might want to ask the question as naturopathic, functional medicine, alternative medicine people, well, what's the cause of that? And might there be environmental exposures or genetics? And there does seem to be a strong genetic link. So the treatment goals are to help her menstruate regularly, meaning to ovulate regularly in this case, provide endometrial protection because she's producing her normal amount of estrogen, not too much estrogen. She's just not producing normal amounts of progesterone because she's not ovulating either at all or certainly not regularly. We also want to reduce her androgens and treat symptoms of excess like the acne, the hirsutism, the hair loss, the body hair anywhere, restore the fertility if desired. And then there's health maintenance issues, reducing a risk of future problems. All those are on our to-do list for PCOS patient. And I've outlined here a sample of treatment plan, just a sample, think of it as a sample. And but I have broken it down to what I consider fundamental, like the things I pretty much probably am always going to do in a PCOS patient. And I didn't think we had time to go over the studies on these, but there is quite a bit of data on N-acetylcysteine at this dose usually and PCOS. So you might want to check that out. It's kind of probably the most the supplement that has it's certainly the supplement that has the most data in PCOS, and it's right up there with the supplement that has the most data in any women's health condition. And then here's that study I referred to, the 40 milligram standardized extract 10 days a month. And then I have my top add-ons. And the biggie in my book is the myo-inositol 4 grams a day. I almost always do that I almost always do NAC and myo-inositol. So I might, even if they don't have very significant acne or hirsutism, we know the underlying cause is on the list is hyperandrogenism. So I really want that myo-inositol in there because that's really what that targets. These other players, nettles root green tea, licorice root, they're minor players in lowering androgens, and saw palmetto, I don't think actually, in my estimation, doesn't lower androgen. It lowers the effect of conversion of testosterone to dihydrotestosterone at the hair follicle. And then we consider some of these other things. And I definitely have on my consideration list metformin and possibly spironolactone as well. But metformin gets at the underlying cause of insulin resistance. What about hyperprolactinemia? Um, we want to for sure have done our due diligence to make sure there's no tumor. Vitex is our main player here, 20 milligrams a day for 3 months. I think I already mentioned that, but lowering prolactin levels. And it can be, here's just again, this bowl lowers prolactin due to its dopaminergic effects, increases serum progesterone, improves pregnancy rates. Now, these are women with PCOS, not specifically hyperprolactinemia, or not only hyperprolactinemia, but B6 also, keep in mind, this is just a very small study. 3 women treated with B6 who had hyperprolactinemia and galactorrhea as a result. Um, the it was able to actually lower or cease the galactorrhea and lower the serum prolactin. What's a little bothersome is the dosing that was used. These can be doses fraught with side effects, worrisome side effects. So I would try to hang with the 200 and hope that there's going to be no peripheral neuropathy. Here's my sample treatment plan. The dopamine is a monoamine derived from tyrosine and or L-phenylalanine. So that is why the L-tyrosine is in there in someone with hyperprolactinemia. And then a little, anorexia nervosa. Well, hypothalamic amenorrhea is mm, a has lifelong consequences, including osteoporosis and fractures if she's not given estrogen, by the way. But if she has anorexia as the cause of her hypothalamic amenorrhea, that of course is a very complex situation. And my treatment plans here, my non-hormonal treatment plans here, I want to stress the same thing that I stress for POI is don't go too long without giving her estrogen. But my main players here are going to be maca, vitex, rhodiola, polyglandular support. But she might also be depressed or anxious, so we can have lots of other natural therapies to address that. Um, and um, and working again, if she's anorexic, we got to bring a team of experts on board for that. And this looks like a duplicate basically of the information before that. Here's some information from up to date on standard of care guidelines for hypothalamic amenorrhea. You really have to consider hormones within a few months uh, because the consequences are just too great if we naively go on and on and on. Um, Baseline bone density, I think, is a good idea both in the POI case and the hypothalamic amenorrhea case. You can use similar guidelines that we did for POI in terms of estrogen, but the 0.1 estradiol patch, double the average menopause dose that you do once a week, or there are patches that are twice a week. And then we would typically, if she wants to bleed, we would cycle our oral micronized progesterone. Don't use a patch with progesterone cream. Don't use a patch with progesterone troches. Those are not proven to protect the endometrium from the estrogen, no matter what ideas you might believe or come up with about absorption. It's just not proven. Um, and there are is my last slide, but I think there's another last slide here. But I just want to point out that I do give seminars 4 times a year, not me, but me and a team of fabulous teachers and educators and clinicians on a range of topics. We have them quarterly. The next one is the menopause hormone boot camp in April. So you would go to the Institute of Women's Health and see what we've got going on. These are currently virtual only seminars, and just a wealth of information, very compatible with things that you are learning from the Dutch test library. And then I think he mentioned this, but here's also a reminder that new providers get 50% off, up to 5 testing kits, and some other all goodies that are listed there. So maybe that's actually decent time management on my part, I must say. So maybe we have some questions.
Yeah, wonderful time management. Thank you so much for a great presentation. We do have a few questions that we can get to. Probably won't be able to get to all of them, just bumping up against that 1 o'clock time hour. But the very first and easy question is, you mentioned a book at the beginning. We had quite a few of our attendees ask what that book is and where they can get it one more time.
Well, it's a big old fat textbook. And I'm pretty sure it's called Clinical Gynecologic Endocrinology and Infertility. And there's 2 authors. Leon Spiroff is one author, and there's another author. And like I said, I think it's not published yearly or every other year. But the last edition that's available, I would look online and you can purchase it. If you just type in
Wonderful.
Clinical Gynecologic Endocrinology and Infertility, Leon Spiroff.
Thank you very much. Next question would be, any herbals that you use to help with an LH surge?
You mean they're not having an LH surge?
Correct.
Yeah, I think I'm sorry if that wasn't gleaned from my information there, but I would go with Vitex, possibly rhodiola.
Perfect. The next question that we'll get to is, does your treatment approach change at all if amenorrhea occurred after coming off birth control for 22 years?
No. Well, you mean, okay. I was so hoping to avoid that one, but I understand the question. Um, so going off of birth control pills is not the cause of her secondary amenorrhea. That's the fundamental thing you have to accept. She has an underlying cause. The birth control pills were masking that cause. Someone probably and either she had the problem way back when and was just put on birth control pills without a proper evaluation. She had periods, great. She had contraception, great. And now she went off and boom, the problem is back. That's one scenario. Or during the course of taking the birth control pills, she acquired PCOS, or that her PCOS evolved, for example. Or perhaps she now has POI, but the birth control pills were not the cause. Something else is the cause. So it behooves us to know what that is.
Wonderful. Thank you. The next question, this will be the last one that we get to today. Is there a limit or a starting treatment for premature or ovarian failure? Example, they stopped having a menses at age 46, but now at 50 years old, no hormonal treatment for 4 years. Should they start treatment because they're less than 51?
Okay, so actually, stopping your menses at age 46 is not premature ovarian insufficiency. Premature menopause, or POI, is stopping your menses before the age of 40 due to that cause. Remember, there might be other causes. So the cutoff is age 40. She's become menopausal apparently at age 46. That's within the normal time range. Becoming menopausal before age 40 is premature. Between the ages of 40 and 45 is early. She's at 46. She doesn't need to go on hormones to protect bones, heart, brain. But if it was before 40 or between 40 and 45, I would vote she should. And if she was 43, she would take hormones until she was about 51. If she was less than 40, she would take hormones until she's about 51. She's 46 and she stopped menses at 46, and if I remember, she's now 51 or 50. So
50, correct.
she could go on hormones if you had a good reason, quality of life issues, or osteoporosis prevention because she's at high risk, mother had a hip fracture, or she has a sucky bone density, or she already has osteoporosis. Those would be the 3 buckets. She could, as long as she's within 10 years of her last menstrual period due to menopause, you can safely initiate systemic hormonal therapy. And that in about 500 times more details are in the menopause hormone boot camp in April. Because it's a really important question. I'm glad you brought it out so I could clarify again the ages, but that below 40, 40 to 45, and then after 45 is there are 3 very different scenarios. But your patient, she's become menopausal at a fine normal age. She can go on estrogen because she's within 4 years of that last menstrual period if you have a good reason for her to go on. It's less than
Wonderful.
10 years.
Yeah,
Okay.
thank you for getting that question. Thank you all again for joining us today. Make sure you check your inboxes tomorrow for a link to the recording and to download the slides. If you do have any additional questions about today's content or for general questions about the Dutch test, please email our customer support team at info@dutchtest.com. Thank you and have a great rest of your day.
Thanks, everybody. Bye-bye.